Hi, I'm Dr. Simon Freilich, consultant in clinical neurophysiology, back with the channel. In this video, I'm going to pick up on the previous one where we're talking about the place of clinical neurophysiology in the intensive care unit, and we're going to be very specifically looking and exploring hypoxic brain injury and its prognosis and how we can help to establish that using clinical neurophysiology techniques. By way of introduction, I think this is an inherently difficult topic. I know there are quite a wide spectrum of people who access these videos, so you may be the family of a patient who is either currently in an intensive care situation or has been in an intensive care situation where there was questions about what the future may hold. You may be a healthcare professional who wants to better understand what we're looking at in terms of the clinical neurophysiology side of things in making those determinations. And really, by making this video, I want to raise the awareness of some of the inherent difficult issues associated with this. I want to talk about intensive care unit survivorship, really, and how we can try and understand who are more or less likely to survive and long-term consequences of that, to explore brain susceptibility to hypoxia, and also very specifically the situation of cardiac arrest. Intensive care units are highly limited resources. I think everyone will have a much better awareness of that now as we are coming through hopefully the tail end of COVID, but we've had some really challenging years. I think everyone in the general public understands it's a very limited resource, both in terms of its highly skilled, knowledgeable staff, in terms of the type of equipment that is there, the facilities, and also the cost as well. And because of all of those different factors, we can all better appreciate these days that it has to have targeted use, and we have to be realistic about the intended purposes and outcomes. And I say this from the perspective of someone who's not only a neurophysiologist and is working in this particular field right now, but someone who's also worked in a variety of different intensive care units, general ITU, neuro ITU, cardiothoracic ITU, and I've seen a tremendous number and spectrum of cases and scenarios, and it's so important to really understand what are we trying to achieve by offering intensive care treatment. So in terms of survivorship, it's important to understand what are the factors that can increase or decrease the likelihood of survivorship, and those will very much depend by the cause, what's brought someone into the intensive care unit, the severity of that particular illness, the general context as well, what the patient's health was leading up to that time, and also what we call nosocomial events, where things can unfortunately happen within the hospital environment for a whole host of factors and reasons beyond control, and they can all play into what makes the possibility and probabilities of survivorship either increase or decrease. We also have to appreciate, and I'm not going to talk about that really in this video at all, the challenges of hospital stays. It's not just about the intensive care unit. There's also the period of time afterwards, which can be long, it can be uncomfortable, it can be challenging, and there are no guarantees. And we'll see shortly that just because someone survives through intensive care unit stay, it doesn't necessarily mean that they will survive until discharge. And apart from the actual stay in hospital, there can be long-term impairments, questions about rehabilitation, and long-term disability as well. So all these different factors have to be included within the calculus of how we use intensive care units and how we offer that service. So there's going to be a fair bit of data that I'm going to be going through, and these will come through some incredible programs. So this one is from ICNARC, and I'm going to be focusing really on the year 2019 for reasons you'll see very shortly. But if we have a look at the different types of reasons that people can be admitted to an intensive care unit, on the whole, a lot of patients are there for either monitoring or support. Most will be cardiovascular or respiratory, about 10% will be for neurological purposes, and a variety of multiple organs can be supported. So most commonly will be single organ or double organ support, but some people will need to have multiple organ support as a reason for their intensive care admission. Survivorship, if we just have a look at the 2019, this is sort of pre-COVID, I want to just sort of focus on that if we may. So survivorship 2019 was overall 86%. We're going to see that's really not the case so much for the cardiac arrest scenario. I don't want to gloss over what's happened since, because actually survivorship has decreased 2020 and 2021. And I haven't seen very many people pick up on this or report it in the news. And that is actually quite challenging and disturbing to understand, why this has been occurring. We'll have a look. We'll pick up on this fairly shortly. But overall, if we look at survivorship in general, up to 2019, it was 86% at the end of critical care, and the subsequent step, which is outcome at the end of the acute hospital stay. So not everyone survives, all the way through. As I've already mentioned, people also have to survive the period afterwards. So really, about 81% will survive overall to discharge from hospital. If we have a look at the mortality by the different type of admission groups, so about 80% of patients will have come as emergencies, majority actually non-surgical, so about 60% non-surgical, 20% following urgent surgery, and about 20% following planned scheduled surgery. If we just have a look over here at what's happened with the mortality rates, we can actually see that the mortality rates have basically increased across every type of admission group, with the exception of COVID. So we seem to be doing better with treating COVID, but everyone else seems to have got slightly worse in terms of the outcome of their treatment. And I suspect, I don't know, but it could be that patients are presenting later to the intensive care units, and that may be impacting on survivorship, because we know that time is so critical to patient state, and depending on how someone comes in, I think really does have a tremendous effect on what happens later on. But if we have a look over here, let's just take a look at sepsis, for example. So if there's sepsis and there's no organ dysfunction, the overall acute hospital mortality is 7%, which is obviously not great. But actually, if there's increasing number of organs that require support, mortality significantly increases. So, once people have got sort of 3 or 4 organs, the chances of passing away are over half. And that's only really increased with time. Similarly for the severity of kidney injury as well, again, mortality has significantly increased. So there are different reasons that people are admitted to an intensive care unit, and that will have its own associated degree of mortality, and they're all slightly different. The brain, this is a neurophysiology channel where we're focused on neurology topics really, is a very delicate organ. It requires a lot of energy, and it's very oxygen dependent. It's very easily affected by trauma, swelling, or raised intracranial pressure. That may either be for direct reasons, if there's been brain trauma, or if there's been bleeding within inside or reduced perfusion. Hypoxia, it's very easily affected by that, whether vascular impairment, either issues with the heart, the pump, or the vasculature, the plumbing, or metabolic and electrolyte disturbances can easily be disrupted, and there can be many different situations which can lead to any of the above, and in combination too. This is a scenario which I get probably about once a year, and I think this just really demonstrates very beautifully what happens when the heart stops working acutely. So this is someone who's got sick sinus syndrome, and this particular patient, as I'm going to show you, has had very acute reversible cerebral dysfunction. Now, I've talked previously about what normal EEG looks like. I'll show you what normal EEG looks like in a moment with the algorithm and so on. But just to appreciate this, you can see all the various squiggles here. The red is for the right side of the brain, the blue is the left side of the brain, and you can see that the brain is chugging along over here. The bottom line here is the ECG, and you can gradually see there's a slight increase in the interval between the heart rate over there, and then it goes into this long pause over here. Okay, now as this pause continues, there is a fall in perfusion to the brain. So about 11 seconds in, you can see that the squiggles of the brainwave activity actually sort of slow down, and instead of being sort of densely packed small squiggles, they become larger amplitude, slower squiggles, and then they abruptly over here they flatten out. And what's happening over here is that the brain is becoming acutely dysfunctional. As you can see written over here is what's happened with the patient. The head goes down, and because they were sitting upright and they were floppy, and they started very briefly shaking over here. This is not heart activity, this is just muscle artifact as the body shakes. And then the brain goes acutely dysfunctional and flattens out. This situation continues for as long as the heart is not properly pumping. The heart kicks in about over here. It starts to have its electrical activity. It starts to squeeze, and I haven't got a blood pressure monitoring with this, but as this happens, you can see over here they start to, it's written they lift their head, they're looking vague, they're not really responding, but actually the brain is beginning to kick back into function, and as it kicks back into function you can see the slow wave activity over here, and then it speeds up as the heart rate settles back in. So this is a very beautiful example of what happens when the heart stops working. Fortunately it was reversible in this case, but you can see this acute dysfunction in brainwave activity. Everything flattens out and then gradually slows. It returns with slow wave activity and then speeds up, and this patient had a pacemaker and lived happily ever after, I'm pleased to say. So when it comes to hypoxia, if it's very short term, then obviously the brain can be dysfunctional for a very short period of time, but when it's prolonged, this can lead to irreversible brain damage, and that will be determined by the duration of the hypoxia, the severity of the hypoxia, what the substrate of the brain is, which means what's the state of the brain before all of this happens. So an old or damaged brain will be more susceptible to damage than a nice healthy one, and also the context as well. This is what a nice normal EEG looks like, and you can see on a separate video on the iCard above what the algorithm is about, but that's what normal looks like. Just contrast this now with someone who, in this example, had COVID and had respiratory distress syndrome for a number of days. They had their oxygen saturations at this point was about 60%, and they were mildly confused, and that's what prompted them to have the EEG. And in this case, the normal brain activity had slowed to about 6 or 7 hertz, and it was mildly encephalopathic, even though the SATs were 60%. And the reason for that is there's been a slow accommodation as the respiratory system has sort of gradually failed in this very particular scenario. Of course, it can fail very acutely as well, and this is a different example. This is someone who aspirated and choked and was fortunately found in time and was intubated, and in the period afterwards, because they wanted to know if there was any brain damage, you can see slow wave activity over here. So there has been some acute cerebral dysfunction, but also these nasty looking triphasic waves over there as well. And fortunately, 10 days later, they were back to themselves and their EEG had normalized. So, acute respiratory dysfunction, acute lack of oxygen to the brain can be reversible if it's caught in time. Again, this is what normal looks like, and this is someone who is post-cardiac arrest with a isoelectric EEG. It's properly flat, and this is flat for the duration of the recording, and here the cortical activity has just frankly been wiped out, and this has a very bad prognosis. This is a situation which is slightly just before that, which is burst suppression with identical bursts, and that was also associated with a poor prognosis. This, by contrast, is someone who's got continuous cortical activity and actually was having non-convulsive status epilepticus. And this is someone over a year after a significant hypoxic event and was left with intractable seizures. So when we're talking about poor neurological outcomes, they can be really devastating, and survivorship does not necessarily equate to having a good quality of life, and in this particular scenario, a very miserable one. This is someone who has got post-cardiac arrest slowing, and over here this is moderate slowing of brainwave activity, and it's difficult to know quite what the future would hold for such a patient in terms of their long-term cognition. This may get better, it may not, and this is someone who has ended up with what we call a theta coma, and they're in a persistent vegetative state. Again, it is a poor neurological outcome, but it can be very difficult to predict this type of future within the intensive care acute setting. This is someone else who was left with mild confusion over a year after their cardiac arrest, again with relatively mild slowing present within the EEG. And so there's a real spectrum of brain injury going from devastating, where we've seen the EEG being totally flat, to these sort of identical burst patterns, to subclinical seizure activities, to slowing, and all the way down to sort of mild transient cognitive impairment. Cardiac arrest is a very specific issue. It's a very common scenario. We have access to very big data about it, which is one of the reasons that I wanted to talk about this. Obviously, there is catastrophic sudden loss of brain oxygenation and perfusion, and that acute energy failure leads to ion exchange mechanism failure, which induces cell damage. So we have an accumulation of intracellular sodium and calcium, there's swelling of those brain cells, release of cytotoxic glutamate and free radicals, there's cell lysis, so the cells burst, and there can be a secondary phase of programmed cell death, apoptosis, which can occur later. And we know that hypothermia can prevent or limit some of these processes, and that's why it can be used therapeutically and is an increasingly common thing that we see in intensive care units. If we have a look at the intra-hospital cardiac arrest data, so this is the National Cardiac Arrest Audit from ICNARC, basically overall about 22% of people who have a cardiac arrest within the hospital setting will be brought back to life and will survive to hospital discharge. The best factors associated with that will be being under 65 really, and having what we call a shockable rhythm. And if we contrast that with the out-of-hospital cardiac arrest, so this is now from NCPOD, they estimate that about 60,000 people will have an out-of-hospital cardiac arrest a year. Half of those emergency services will be called out, and there'll be an attempt at resuscitation. About half of those, unfortunately, will already be dead or not be able to be transferred to hospital. Within the half that is transferred to hospital, it then splits into 2/3 will have had a restoration of their circulation by hospital handover. Of those, about a quarter will survive to discharge. So overall, we're talking about 8% or so of those with out-of-hospital cardiac arrests will survive to discharge. However, for the third that have got no spontaneous circulation by the time that they are handed over to the hospital staff, their survival to discharge is almost minimal. And so time matters. Cardiologists always love to talk that time is muscle, but as a neurologist, time is also brain. And it's not just about surviving to hospital, it's also what's going to happen in the thereafter. The most important factors from all of that data is that it's important in terms of survivorship for a cardiac arrest to be witnessed, for there to be early bystander CPR and early defibrillation where that's applicable. That's why we have all these sort of defibrillators out around in the public. So neurology input is very common in these post-cardiac arrest situations in intensive care units. Can be very challenging. Many patients can be either confused or obtunded. About 80% will have impaired levels of consciousness. Many will be sedated or undergoing therapeutic hypothermia during the initial assessments, and all of these things make clinical assessment of brain function very difficult, and that's particularly important when making these very big treatment decisions. Data shows that a lot of patients will have significantly reduced GCS, and these can relate to hypoxic brain injury, the effects of sedation, therapeutic hypothermia. There may be a variety of organs failure which may be contributing to this, and there may be sepsis as well. And all of this makes challenging assessments of neurological state and the determination of any hypoxic injury. So in terms of prognostics, what does the future hold? There are different modalities. We know that there is clinical assessment, there is imaging, of which there's a variety of different types, whether it's MRI or CT. There's clinical neurophysiology with EEG and evoked potentials, and there are also blood markers as well. And very specifically, when it comes to the neurophysiology, it's not available everywhere. And as we can see from this data from NCPOD, it's available in about 60% of hospitals with this very specific regard. So prognostication is usually multimodal. We don't like to rely on a single marker. The timing of those studies and those probabilities is very important as to when we do it. They're always contextual. Temperature has to be considered, and confounders as well. In terms of what clinical neurophysiology has to offer, we have the EEGs, which we talked about, where we can measure in real-time cortical activity. We can identify a whole range of different issues, which makes it useful not just for thinking about hypoxic brain injury, but also if there's underlying seizure activity or some form of encephalopathy. Timing is very important. We want to exclude confounders. We talked about temperature, the lasting effects of sedatives, and so on. And there's a whole spectrum of EEG patterns of dysfunction, but it is most particularly helpful at the extremity of dysfunction. The other thing to talk about are evoked potentials, where we measure the cortical response to a stimulus, usually arising from the hand, and we track the passage of that signal up through the brainstem up to the cortex itself. And it's a very robust test in intensive care unit conditions, and because it's looking at the signal passage through the brainstem, if it's not there, actually it can be a very useful, very highly accurate marker of dire outcomes, which is a very useful thing very early on, but generally they aren't used very early. So the fact that they can predict what the outcome is at 24 hours, that isn't usually the time that we start thinking about prognosis. We're usually busy trying to recover the patient very actively at that point, usually with therapeutic hypothermia and so on. And that's not the time that we really get busy trying to work out what the future may hold for the patient. The presence of responses, though, doesn't actually predict a good outcome. So the fact that a response may be there just means that it's not necessarily imminently dire, but it doesn't mean that the patient will survive. I just want to finish by highlighting this very fascinating, very important study from the Telstar group from the Netherlands. They had a look at the more aggressive treatment of electrical discharges within the brain following cardiac arrest, and what they found was trying to suppress this type of activity did not improve the outcomes for patients. So a very important study to have a look at. So in summary, whilst intensive care unit survival is generally quite good, let's call that about 80%, cardiac arrest, particularly those out of hospital who've taken a while to get that treatment with catastrophic hypoxia, have a poor outcome overall despite best efforts, and that can result in very severe neurological impairment, intractable seizures, persistent vegetative states, and death. There is a role for clinical neurophysiology studies in supporting the neurological clinical assessment and imaging in determining poor outcomes, and it's important to appreciate that even for survivors there can be very long-term, very serious neurological impairments and complications. So I hope that this video helps to raise awareness really of some of the issues, some of the complex decision makings around the ceilings of treatment, and it's just generally a very difficult subject to discuss, so I think it's just been very helpful to sort of talk this through in this way. Thank you very much. I hope you found this useful. Please do support the channel by liking, sharing, and above all subscribing, and I look forward to seeing you in the next video, hopefully shortly. All the very best.